Good morning, everyone. Myself, Dr. Pankaj. I'm pediatrician by profession and teacher by passion. Welcome you all in Pedia Academy by Dr. Pankaj. So, today we are discussing our first lecture on this series, that is Neonatology IINI SS Fast Track Revision Series. In today's video, we will discuss neonatal neurology. Actually, we will be touching upon important concepts in neonatal neurology and high yield topics. We will be discussing only ultra high yield topics which are often confusing, repeatedly asked. We are not giving I'm not giving full-fledged review of neonatal neurology here, but it is very important. By doing this, you will be able to solve many questions from neonatal neurology. So, without wasting time, we'll starting this session. But before that, I want your 100% attention in this lecture, because this is very much important and often ignored and very much asked in neonatology. Okay, so without further delay, let's start our discussion of neonatal neurology. Okay, so we'll start first from definition of parental asphyxia, very much important. 3 to 4 times they have been asked like this. WHO says failure to initiate or sustain breathing is called as perinatal asphyxia. NNPD network definition is very much important. They have classified this parental asphyxia into moderate and severe parental asphyxia. Okay, they are saying on APGAR score or breathing. Okay, just remember, or word is there, means they are saying either of breathing pattern or APGAR score. We'll discuss APGAR score first. If APGAR score is 4 to 6 at 1 minute, they are talking about APGAR score at 1 minute, not at 5, 10 or 20 minutes. We will discuss them later. But for this definition, they are discussing APGAR score at 1 minute. If it is 4 to 6, no any other thing given, moderate PA. If APGAR score is 0 to 3 at 1 minute of age, it is severe parental asphyxia. But wait, if only slow gasping breathing is present, it is moderate PA, and if no breathing is there, it is severe PA. Any of these, either no breathing or APGAR score is 0 to 3 at 1 minute as severe parental asphyxia. As we understood, this is incomplete definition. So, American Academy of Pediatrics and American College of Obstetrics and Gynecology (ACOG) came forward and they proposed one definition of parental asphyxia which has strict criteria. This says presence of all of the following, very much important. You have to consider this word all. All is very important. All things should be there. What are all things? Profound metabolic or mixed acidosis, that is pH less than 7 in umbilical cord blood. Okay, pH less than 7. Remember, they haven't mentioned any bicarbonate deficit or base deficit here. They are just mentioning pH should be less than 7 in umbilical cord blood sample. Plus, persistence of low APGAR score less than 3 for more than 5 minutes. They are talking about 5-minute APGAR here, because transient APGAR might be low. We can't classify them in parental asphyxia. So at 5-minute APGAR score, it should be less than 3. Plus, just remember, it is plus. Signs of neonatal neurological dysfunction, that is seizures, encephalopathy and tone abnormalities should be there. Okay. Plus evidence of multiple organ failure, that is kidney, lung, liver, heart and intestine. So by far you have understood, आप having very strict criteria. pH should be less than 7, low APGAR score less than 3 at 5 minutes, severe neurological dysfunction and multiple organ failure. So by doing this, they are actually discussing this criterias, which are strict criterias. Okay. Another thing, they are discussing about organ system dysfunction in parental asphyxia. What are the organ system dysfunction? In CNS, we know HIE, intracranial hemorrhage, and long-term neurological sequelae. All we know. Cardiac, what happened in cardiac? Just see, myocardial dysfunction can occur, valvular dysfunction can also occur in HIE. Important rhythm disturbances in CCS can occur. Renal, hematuria, acute tubular necrosis, and renal vein thrombosis. These are important consideration in HIE. GI tract, NEC can occur in hepatic dysfunction. Pulmonary, we forgot. Pulmonary, delayed adaptation, respiratory failure, meconium aspiration, surfactant depletion. Very much important. Surfactant depletion is a part of sequelae of perinatal asphyxia. Primary pulmonary hypertension, hematological thrombocytopenia, just see, not anemia, not any WBC abnormalities, thrombocytopenia, coagulation abnormalities, metabolic acidosis, hypoglycemia, hypocalcemia, and hyponatremia. So in this busy looking table, they can ask 5 to 7 questions. What is WHO definition? What is NNPD definition? What is ARP definition of perinatal asphyxia? And what are the organ systems which are involved, symptoms or characters of abnormalities in those systems? Okay, going forward to next slide. SARNAT and SART examination. It is modified actually, and it has been continuously being asked NEET SS examination along with INI SS examination. Okay, what are the features you have to remember? This is modified. Level of consciousness, spontaneous activity, posture, muscle tone, primitive reflex, and autonomic reflex. They can ask which is not included. So these are included, just remember. Among them, which is actually mild, moderate, and severe, everything is going less, like level of consciousness hyper alert to lethargic to minimal, spontaneous activity slightly decreased to decrease, absent, posture. Mild distal flexion seen in mild variety, distal flexion and complete extension seen in moderate. So complete extension seen in moderate, decerebrate in severe. You have to remember these, very much important. Muscle tone, hypertonic in mild, hypotonic in moderate, and severe in flaccid in severe. Very much important. Suck and Moro's reflex are normal, weak to absent. So these are gradually decreasing. Pupils, they are constricted, caution in moderate, and in severe, dilated or either fixed or sluggishly reactive, asymmetric. Very much important. Mild, they haven't mentioned pupil. You can comment as mydriasis, but mydriasis with fixed pupil is example of severe Sarnat and Sarnat staging of HIE. Okay, this is very much important. You have to remember. Just pause this video and just revise this Sarnat. This is modified staging. Another score is Thompson encephalopathy score. Again, very much important. We will see important thing. Muscle tone, we discussed it. In muscle tone, everything will decrease. Level of consciousness will decrease. Seizures, very important. If score 1 is there, infrequent, less than 3 days of seizures, score 1 will be given. If more than 2 per day seizure, score 2 will be given. Very important. Okay, fisting, crying, score 1, and strong distal flexion, score 2, and score 3 is decerebrate. Very much important. Okay, just see respiration, hyperventilation, score 1, brief apnea, score 2, and apnea is 3. Just see what all are included in Thompson encephalopathy score. Just go through, pause this video here and just revise them. Muscle tone, level of consciousness, posture, Moro's reflex, Grass reflex, suck reflex, respiration, fontanelle. Okay, in this video we will not discuss pediatric neurology. We will be discussing only neonatal neurology. If you are interested in pediatric neurology fast track revision, I have made a separate video on pediatric neurology fast track revision. You can see in playlist also, where you can revise that pediatric neurology part. Link of that is in description. Okay, so going forward, clinical feature of severe HI and timeline. It is very important for AIIMS examiner. They are fond of asking this. Okay, birth to 12 hours. What happened in birth to 12 hours? Decreased alertness and tone, all we know. Convergence starts, if they starts in birth less than 12 hours, they are of severe or poor significance. periodic breathing, respiratory failure, intact pupillary and oculomotor response. So, pupillary and oculomotor response is intact in within 12 hours. What happened in 12 to 24 hours? Change in alertness level, all we know, apneic spell, increase in convergence, jitteriness, weakness in proximal limb. Okay, in term neonate, upper limb are more involved than lower limbs. Preterm lower limb are more involved. Why we'll discuss them later, but the weakness, motor weakness actually arises in 12 to 24 hours of time. Okay, after we'll discuss 24 to 72 hours. In this, we'll discuss further decrease in alertness, pupillary and oculomotor disturbances which were intact in initial part, they are abnormal in this after 1 day. Respiratory arrest, very important consideration is preterm neonate, intraventricular hemorrhage and periventricular hemorrhagic infarction PVHI are seen in second day, very much important consideration. Okay, after 72 hours we are able to see abnormal sucking, swallowing, gag and tongue movement, hypotonia more common than hypertonia, weakness in proximal limbs. Okay, so in exam they can ask any question about this timeline. Again, I'm saying you give your 100% attention here. Just pause this video and just revise this timeline again and again because this is hot favorite topic or of AIIMS examiners. Okay, here there is this MRI image of selective neuronal injury. First image is flare and second image is diffusion weighted MRI, which is MRI of choice immediately in first day. Okay, so here what we discussing in this first image, we are able to see the slow signal in putamen. Okay, but in diffusion weighted MRI, we are able to see diffusion weighted MRI, we are able to see signal intensity in frontal cortex along with basal ganglia abnormalities. We will later discuss basal ganglia abnormalities are considered as severe abnormalities in case of HIE and they have significance. We'll discuss them later. Going forward to next. Okay, this slide is very important. Again, just give you 100% attention in this slide. At least 3 to 4 questions are potential question from this slide. Prognostic factor in HIE, very much important. First we will discuss EEG. Okay, if we did EEG in HIE, what are the prognostic factors which shows this patient is going to do worse? Okay, if EEG is long period of inactivity more than 10 seconds. In exam, they will ask long period of inactivity 5 seconds, 10 seconds, 20 seconds, etc. It should be more than 10-second question. Okay. Another brief period of burst less than 6 seconds with small amplitude burst. Okay. Any burst means something neural circuits is like short circuit type thing you can understand. Brief period of burst less than 6 seconds with small amplitude burst, it is worse prognosis. Interhemispheric asymmetry asynchrony, basically the connections are going haywire, that's why asymmetry is there, it is not a good sign. Isoelectric or low voltage, what low voltage they have asked once, less than 5 microvolt. So if anything going flat, be it ECG or EEG, it is not a good. So you have to remember all the 4 conditions like low period inactivity more than 10 seconds, brief period of burst, asymmetry and isoelectric or low voltage EEG. Okay. Okay, now they'll ask amplitude integrated AEG. We know this is actually EEG of choice in neonatal period, but what are the poor factors which shows this AEG is poor in HIE patient or prognosis wise? So if just see, if wide fluctuation in amplitude with baseline voltage dropping to near zero, if wide fluctuation in AEG, it is poor prognosis. Peak amplitude under 5 microvolt, again it is very poor prognosis. And seizure spike, if you are able to spot in AEEG, it is of poor prognosis. Just pause this video and remember EEG and AEEG findings in HIE. Okay, again very much important predictors of mortality and neurological morbidity after perinatal hypoxemic insult. Generally, how you will predict or you will tell parents that your child is going to do well, they will ask you. You have experience in NICUs, they generally ask what will be the future of child, will be he will be able to come to normal life or not. So just see, if extended very low APGAR score at 20 minutes or more, then you can say them it is of poor prognosis. Time to establish spontaneous respiration, 30 minutes it took to establish spontaneous respiration, it is of poor prognosis. Neonatal neurologic examination, if it is abnormal, yes. Brain imaging you can see in other investigation. Okay, so this is basic parameters given, but Nelson digs deep after that. So what they say, we will Nelson say they will dig deep and give you precise thing. Okay, so Nelson says low 0 to 3 10 minutes APGAR score. AIIMS protocol says about APGAR score 20 minutes, but Nelson says if 10-minute APGAR score is low, less than 3, it is suggestive of poor prognosis. Need of CPR in delivery room. If CPR is required in delivery room, it is of poor prognosis. Delayed onset, more than 20 minutes of spontaneous breathing, not 30 minutes, 20 minutes, it is of poor prognosis. Severe neurological signs like coma, hypotonia, hypertonia. Seizure onset in first 12 hours is difficult to treat. We have discussed it. If seizures are coming in first 12 hours, it is of poor significance. Severe prolonged more than 7 days EEG finding includes burst suppression pattern. Okay, if burst suppression pattern is going more than 7 days, it is of poor prognosis. MRI showing basal gangliothalamic lesions. We have discussed the MRI image just now. In this basal gangliothalamic lesions, if they are present, they are suggestive of poor prognosis. Oliguria or anuria is more than 24 hours, suggestive of multi-organ failure. Abnormal neurological examination more than 14 days. So, actually, these are very important. Nelson says what Nelson says about EEG. Okay, so some patterns are favorable outcome in EEG, that is mild depression or less on day 1, normal background on day 7. So we are not concerned with good factors, we are concerned with unfavorable outcome which can guide us for prognosis of HIE. So just see, predominant interburst interval is more than 20 seconds at any day. Very much important previous INISS question. Burst suppression pattern on any day. If burst suppression is seen any day, it is of actually poor prognosis. Isoelectric tracing on any day, and mild or greater depression after day 12. So we have discussed all prognostic factors. My advice to you all, just pause this video, revise them again, and after you have thorough with this classification or prognostic factor, then just move forward. Okay, so going towards next, these are abnormal EEG patterns we have discussed. This image can be asked. This is actually continuous normal pattern. This is normal pattern. This is actually a discontinuous normal voltage, means normal voltage is there but it is discontinuous. Burst separation, how burst separation is looks like, just see, this is burst separation, this is poor prognosis. Low voltage, that is also poor prognosis, and flat waves, or we can able to see. Okay, so what Nelson says, detection of severe abnormalities like flat wave, burst suppression, and continuously low waves, like these things in first hour of life, very much important, has positive predictive value of unfavorable outcome in 80 to 90% in first hour. If we are able to see these 80 to 90%, it is poor prognosis. Severe abnormalities may improve within 24 hours. Again, this question is very potential question. 50% of birth suppression and 10% of uh, flat tracing can improve within 24 hours. Again, very much important. Rapid recovery of severe abnormalities associated with favorable outcome in 60% of cases. If it is rapidly recovered, yes, it actually generally more good outcome. The combination, this statement is very important. The combination of early neurological examination and early AEG enhances the positive predictive value and specificity. Very much important. This image can be asked. This image is suggestive of parasagittal cerebral injury and signal intensity. You are able to see increased signal intensity in basal ganglia and thalamus bilaterally, which is actually also important and not a good sign for baby. Okay, going forward to next. In this, we'll discuss therapeutic hypothermia guidelines. Okay, which whom we will treat or whom we will not treat. Okay, so if patient or baby is more than 36 week, so can we give therapeutic hypothermia to preterm babies? Yes, we can give, but it should be more than 30 equal or 36 week. Age should be less than 6 hours. It should not be more than 6 hours. Admission temperature should be 36 to 37.4. These should be the first criteria, and following features should be there. Any one features of following should be there. Okay, which are the features? Like evidence of moderate to severe encephalopathy should be there, and any one of evidence of perinatal asphyxia like pH less than 7, base excess minus 16 in cord blood within 1 hour of birth. Very important. Apgar score is less than 5 at 10 minutes. PPV for at least 10 minutes, and history of acute peripartum events like cord prolapse and uterine rupture. Just think, pause this video. What we have discussed just now, it is having 3 to 4 questions. Okay, any patient if more than 34 week, we will not give hypothermia. If 37 week neonate presenting after 12 hours, we will not give therapeutic hypothermia. Okay, and if there is no evidence of encephalopathy, moderate to severe, if it is mild encephalopathy, we will just avoid. Okay, and if any, like any one should be present, just remember any one criteria. So these are entry criteria for therapeutic hypothermia. We will give it up to 72 hours. Okay, we will monitor patient and we will see, but these criteria are very important. Just be thorough with them. Okay, so this is ischemic cerebral injury. This image showing MRI image showing ischemic cerebral injury, very much important. This is actually lesion distribution of main branch of left middle cerebral artery. This is diffusion weighted MRI which is showing clearly. Okay, so this image can be asked. It is actually middle cerebral artery ischemia. Okay, so topography of hypoxic ischemic encephalopathy is important. What we will discuss two important things here. First is parasagittal injury, which is seen in term we have discussed earlier also. So, which region is specifically involved in parasagittal? Posterior. Again, previous year INI SS question. Posterior is very important. Proximal limb weakness is seen. Upper extremity is more involved than lower extremity. Very much important. So what seen in parasagittal injury is spastic quadriparesis along with very important cognitive delay, visual and auditory processing difficulty. So this involved higher cortical functions also. Periventricular injury, this is seen generally in preterm infant. What happens in this injury to motor tract, especially lower extremities? Spastic diplegia is seen, but cognitive and visual auditory functions are generally normal. They can be involved later also, but classical periventricular injury, they are generally normal. And bilateral symmetrical weakness in lower extremities. This word is very important, bilateral and symmetrical. Okay. Other are focal ischemic necrosis. We have just seen MC territory. The hemiparesis, seizures and cognitive delay can be seen in this. Other one is selective neuronal necrosis, in which cognitive delay, cerebral palsy can be seen, because this is cortical area involvement, very much important. Okay, so uh, if we do MRI in first week, what will be the finding? Nelson mentioned them. Cerebral cortical gray white differentiation is lost, very much important. Okay, basal ganglia thalamus high signals can be seen. We have seen them. Parasagittal cerebral cortex subcortical white matters in problems can be seen. Important thing what I'm discussing here, diffusion weighted MRI is more sensitive than conventional sequencing MRI, especially first day after birth when former shows decreased diffusion. Very much important, diffusion weighted MRI. So this HI discussion is very important. Okay, going forward to next slide, ultrasound diagnosis of periventricular leukomalacia, very important potential question. If first week, in first week, we are able to see echogenic foci bilateral, but they are more common in posterior part than anterior part. It is seen in first week, very much important. Echolucent foci, which are cysts. Cysts are seen in more than in 1 to 3 week. Very much important. Cyst, echolucent foci. Ventricular enlargement, often disappearance of cyst is seen in more than 2 to 3 months. Cyst generally disappear after 2 months. Very much important. It can be potential question in your upcoming exam. Echolucent foci and cyst are seen in 1 to 3 week, and the echogenic foci are seen, which are seen in first week, are more in posterior part to anterior part. Okay, so this was about periventricular leukomalacia. Now I discuss some birth injuries. Okay, important is Erb's palsy. You are able to see muscles of shoulder, arm chiefly affected, elbow is extended, wrist is flexed, but grasp is normal. Again, important question. In Erb's palsy, grasp is normal. This patient showing Klumpke's palsy, muscle of are forearm and hand are generally involved. Horner syndrome can be associated with Klumpke's paralysis, and in this grasp is weak. So in this grasp is weak. So 2 point about grasp and Horner syndrome can be seen in Klumpke's paralysis, very much important. Going forward to next. Okay, this is actually a flow chart from Avery's. It shows after severe basal gangliothalamic injury, what happened and what percentage cerebral palsy. 98%, mostly severe. So this is very important consideration. Basal gangliothalamic injury, if they are severe, they produce approximately 98% of cerebral palsy, which is of severe variety. Feeding affected in 90%, you have to do gastrectomy, and prognosis after that depends on Pohn's involvement. You need not to remember this. 90% have gastric problem, feeding problem, speech problem 95%, vision 50 to 75%, DQ is less, seizures. Okay, this is potential question. In severe basal gangliothalamic involvement, if seizures probability, if cortex is normal, seizures can be seen in 25 to 30% patients. If cortex is mildly involved, 45 to 50%. If cortex is moderately involved, 60%. If cortex is severely involved, 75% patient can be seen as seizures. Okay. Going forward to next, investigation required in neonatal with seizures, very much important. They will ask which are essential investigation one must do in case of neonatal seizures. So just remember, they can ask all of the above except question: blood sugar, serum sodium calcium, CSF. Yes, CSF essential investigation in neonatal seizures, cranial ultrasound and EEG. Okay, just remember, MRI is not essential, but CSF is essential, blood sugar and serum sodium and calcium are essential. Other investigation are not essential, but we can do like hematocrit, we can do serum bilirubin, serum magnesium if calcium is low. ABG we can do, imaging like CT, MRI we can do, TOT screen we can do, and workup for inborn error of metabolism. They will ask a question on essential investigations only. Okay, so you have to remember some genetic association of benign neonatal familial seizures and progressive epilepsy syndromes. Benign neonatal familial seizures, they are caused by in one of the following gene mutation like KCNQ2, KCNQ3, SCN2A. Other genes you don't have to remember, just remember three genes. Okay, and remember KCNQ2 can also cause progressive epilepsy syndrome, but KCNQ3 and SCN2A produce benign neonatal familial seizures, very much important. Okay, going forward to next slide. In this slide, differential diagnosis for neonatal seizures are seen. Just pay attention. Benign neonatal sleep myoclonus. This is most common entity misdiagnosed as seizure in neonate. Again a question. Okay, so what happened? Neonate is healthy and birth to 3 months it is seen. Statement based question can be asked. They are seen up to 3 months. Okay, they presents only duration during sleep and upon waking up jerking seizures. So, as name suggests, they are present only in sleep, seen up to 3 months of life, and they are generally commonly mistaken. Jitteriness, on the other hand, okay, in this condition, what happens? May exposure to maternal abuses, hypoglycemia or parental insult. Okay, so these are low amplitude, high frequency, low amplitude, and oscillatory, not jerking movement. So description of jitteriness seizures can be asked. Okay, so how they decrease? Flexion of extremities and gentle stopping of these the extremities can stop them, very much important. Apnea of prematurity. We all know apnea and bradycardia is seen in AOP, but if apnea is associated with tachycardia, it is suggestive of seizures, very much important. So you have to remember differential diagnosis for neonatal seizures, they are very important. Going forward, this is algorithm of management of neonatal seizures. We have to remember in this condition, just see in what we have discussed, secure airway, start oxygen. Okay, so this is very important, IV access and send investigation. So airway, oxygen, IV and send blood investigation. This is normal. So if what you do, if patient is hypoglycemic, blood sugar is less than 40, administer 2 milligram per kg of 10% dextrose followed by infusion. If blood sugar is normal range, check calcium. If calcium is low, 2 ml per kg of 10% calcium gluconate under cardiac monitoring. If seizures continue despite correction of hypoglycemia, 0.25 ml of 50% mag self given intramuscularly. Very important. I am dissecting this. First, you have to see sugar and correct it. Then you have to correct calcium and you have to correct magnesium. Okay, doses we have discussed, but these sequence of these will be like this: sugar, calcium, magnesium. If they are persisting, very much important, we have to give phenobarb over 20 milligram per kg or 20 minutes. We can repeat phenobarb up to 40 milligram per kg, very 20, then 10, 10, very much important. After phenobarb, if the seizures are still persisting, we have two options. Just remember, we have two options. Aptoin we can give, levetiracetam we can give. The dose will be same of aptoin 20 milligram per kg, same for levetiracetam. Aptoin we can repeat after the first dose 10 milligram per kg per dose more, but for levetiracetam we can go up to 60 milligram per kg. Okay, we have given phenobarbital, aptoin or levetiracetam, but seizures are still continuing. We know what we can do. We will go for midazolam bolus, other anti-epileptic drug. Okay, just pause this video and just revise this simple looking neonatal seizures protocol once again, because in exam we are generally actually do mistakes in this. They are fond of asking neonatal seizures management. Okay, going forward to next slide. When to stop anti-seizure medication? Very much important. They say stop anti-seizure medication immediately if seizure is due to transient metabolic abnormalities. Okay, if patient, एक neonate is having seizures, you stop seizure by midazolam or any other drug, and it hypoglycemia, hypocalcemia, and hypomagnesemia was found. So, in this condition, we found a cause, just correct hypoglycemia, magnesemia, or hypoglycemia, and stop anti-epileptic drug. First case scenario. If second case scenario it was not there, so just continue phenobarbital. Stop any other drug if seizures are stopped. Okay, so perform neurological examination prior to discharge. Very much important. First neurological examination prior to discharge. If it is normal, just stop phenobarbital immediately. Okay, so first neurological examination, if it is normal, just stop it immediately. But if it is abnormal, you have to tell to parents, please continue this phenobarbital and come after 1 month. Okay, patient is coming after to you after 1 month. You did neurologic examination. If it is normal, just stop. No, taper over 2 weeks, very important. So in first just discharge, if neurological examination is normal, just stop immediately. But at 1 month of interval, when patient was taking phenobarbital for 1 month, you can't stop that drug immediately. If neurological examination normal, just taper over 2 weeks. But what happen if repeat neurological examination is abnormal? Do EEG. If EEG is normal, then okay, you can consider stopping after over 2 weeks. But if EEG is abnormal, reassess and at 3 months. Okay, call the patient at 3 months of age. So this protocol is very important. Many questions are asked. Many clinical scenarios can be made by just remember, just try to analyze this table, this protocol, and you'll able to give answer clearly. Okay, going forward to next, we are going to intraventricular hemorrhage. This question was asked in TSS exam, recent exam also. There are two grading system of IVH, Papillon and Volpe. Just remember, first isolated germinal matrix hemorrhage is one. IVH without ventricular dilatation, grade 2, NEET SS 25 question, and uh, grade 3 IVH with ventricular dilatation, and grade 4 IVH with parenchymal hemorrhage. If Volpage classification to be considered, stage grade 1 is considered with no or minimal IVH with germinal matrix hemorrhage less than 10% ventricle volume. Grade 2 IVH occupying 10 to 50% of ventricular area on parasagittal view, and grade 3 IVH occupying more than 50% of ventricular area on parasagittal view. Very important. And periventricular echo density is separate notion. So you have to remember these Papillage and Volpage criteria. Again, just pause this video and mug up or try to understand this. Okay. So long-term outcome of these hemorrhage, what happens? This is also potential question in grade 1. What are the incidence of definitive neurologic outcome? 15%. Grade 2, 25%. Grade 3, 50%. Grade 3rd or PVHI, 75%. Okay, so just remember them in rhyme: 15, 25, 50 and 75 in 1, 2, 3 and PVHI. So this table is itself is very important. Going forward to next. Okay, so what are the criteria of hydrocephalus? These are a hot favorite topic of examiner. Okay, so what they say, they will ask normal head growth. So between 26 to 32 week, it is 1 millimeter per day, and between 32 to 40 week, it is 0.7 millimeter per day of head growth they will ask. But just remember one figure: if persistent increase of 2 millimeter per day should raise suspicion of hydrocephalus, just they modify this figure: more than 4 millimeter in 2 days, same thing; more than 15 millimeter a week, The same thing is hydrocephalus. Just remember more than 2 millimeter per day. What are the other criteria? They will ask Doppler ultrasound of anterior and middle cerebral artery, resistive index RI, very much important. They'll say more than RI is more than 0.85 suggests intracranial pressure increasing, and RI is 1 absent diastolic flow perfusion. Okay, another important question which has been frequently asked, what are the therapeutic indication of performing therapeutic CSF in case of hydrocephalus? So, first indication is HC more than 2 millimeter per day, 14 millimeter per week, which is the definition. And on Levene staging, very much important. If this has been actually two times asked, previous year's question, Levene index is greater than action line more than 97th centile plus 4 millimeter. Just remember, it is not more than 97, 97 plus 4 millimeter. Okay, featured of raised ICP and resistive RI, that is 0.85 on Doppler intracranial vessels. Very much important. You have to remember all these ultra high yield. Okay, so as we are discussing this INISS based neonatal neurology, very ultra high yield. If you want to revise pediatric neurology fast track, I have given link in the description. You can go there and do revision of pediatric neurology. It also. Okay, so coming back to topic, the factors which are leading to intraventricular hemorrhage, just can go through increased cerebral blood flow, fluctuation blood flow. You can just go through. Okay, going forward to next slide, very important, and this is potential question. So what are the proposed risk classification management of patient of PHVD? Okay, so in this condition, post hemorrhagic ventricular dilatation, so they have divided into green zone, yellow zone and red zone. Just remember the criterias of green zone. In this VI means ventricular index is less than 97th percentile, AHW, that is anterior horn width, less than 6 millimeter, and absent of any severe features. Don't remember severe features, absent of severe features. Just see if it is less than 6 millimeter or VI less than 97th percentile. Just observe the patient, do USG, nothing else. Green zone. But if it is more than 97th centile and ASW that more than 6 millimeter, and TOD, what is TOD? Thalamo-occipital distance more than 25 millimeter, and these are absent. So these are absent. Just see these are present. VI more than 97, ASW more than 6 and TOD more than 25. What you have to do? You have to do LP. Just I am simplifying things from this complex looking table. You'll do LP. In red zone, what happened? VI is more than 97 plus 4. AHW is more than 10. TOD more than 25. In this condition, plus any of the following is present, like head growth is more than 2 centimeter per week, separated sutures and bulging fontanelle area. What we'll do? We'll do LP and neurosurgical intervention. So first in green zone, do nothing, just observe. Yellow zone, do LP, and red zone, do LP plus neurosurgical intervention. Any clinical risk criteria are there? Red zone. Yellow and green zone can be differentiated by VI and AHW criteria. So just pause this video and revise this. Okay. So this is actually given in this protocol is given. I'm just simplifying this protocol. What you will do, your LP ventricular drainage and ETV CPC VP. So what are ETV? Basically this is just you, if you want to go through this complex looking diagram, you can go, but what I'm telling you, just remember. Okay, yes, I'm telling you, ventriculo-subglial shunt VSGS shunt is used in less than 1.5 kg child. Okay, so this is algorithm of management of PVHI we have just discussed. Okay, spina bifida, which poor prognosis lower bar criteria are used, which is previous year question. What are the poor prognosis? Severe paraplegia, gross enlargement of head, severe kyphosis, scoliosis, and associated gross congenital abnormalities. So they have been asked good prognosis. We need not to remember, we have to remember what are the lower bar criteria of poor prognosis in spinal bifida independent INISS question. So going forward to next. Okay, so this is diagnostic approach of neonatal hypotonia. So just go through once, just pause this video. I'm just simplifying it. Okay, so if you find hypotonic features which are suggestive of central hypotonia, see seizures and encephalopathies present or not. If they are present, do MRI brain and do find etiology. But if seizures or encephalopathy are absent, do chromosomal microarray and consider other genetic test. Simplify, just remember by simplifying it. If features suggestive of neuromuscular weakness, do SMA testing, do congenital muscular dystrophy testing. CPK is very important. If it is elevated, just do congenital muscular dystrophy diagnosis, and if they are mildly elevated, do CMS and genetic testing and muscle biopsy. Basically, we have to differentiate the hypotonia into central and peripheral and go according to that. This is simple flow chart. Just pause this video and go through it. Okay, so this is screening scheme we have discussed in this pediatric neurology fast track revision video also, but just see what are the developmental delay upper range at 3 months, 6 months, 9 months, 12 months, 18 months, 24 months, and this I will not discuss. Just go through this table. This is very important. Just pause this video and go through this. Okay, timing of selective primitive reflex. AIIMS examiners are fond of asking. Palmar grasp appears at 28 week of gestation, fully developed at 32 week, duration is 2 to 3 months postnatal. Routing onset is 32 week of gestation, fully developed at 36 week of gestation, duration is 4 to 6 month postnatal. Morose 28 to 32 week of gestation, fully developed at 37 week, duration is 5 to 6 month postnatal. Tonic neck reflex is 35 week of gestation onset, fully developed at 1 month postnatal, and duration is 6 to 7 month postnatal. Parachute 7 to 8 month postnatal is onset, fully developed at 10 to 11 month, and remains throughout the life. So you have to remember all of this, mug up this, very much important. Going to next last slide of this discussion, we have discussed in pediatric also. Just see image based questions can be asked. This is midline sacral hemangioma in neonate. This is actually capillary malformation with subtle patch of hypertrichosis in dermal sinus. This is human tail, and this is midline area of hypertrichosis overlying a patch of hyperpigmentation, and this is periventricular nodular heterotropia. So we have discussed this neonatal neurology. I know this is very neonatal neurology, very vast. I tried to cover the important or ultra high yield topic of neonatal neurology, which are often confusing and often asked in exam. Just go through this video again and just try to revise this from this video only. You will get good like 60 to 70% of hold of neonatal neurology from this video. Any of your suggestion comments are most welcome. We'll be continuing this series of neonatal fast track revision in upcoming days also. Any suggestion from your side, any comments, you're most welcome. We have actually created a telegram group also where we'll discuss the questions and MCQs also. So till then, stay tuned, do share, like and subscribe. We'll meet in another video.